Hi, my name is Amy Haskamp. I'm a pediatric clinical nurse specialist with the Pediatric Palliative Care team at Riley Hospital for Children in Indianapolis, Indiana. My backdrop is not of Indiana, it's actually of Napa Valley, because if you were seeing Indiana, besides right now, you'd see snow and ice. Otherwise, in the summer, you'd see cornfields. So this is a much more attractive view behind me. I'm so glad to be here with you guys. I'm planning on talking about managing depression in the pediatric palliative care patient. Um, we're going to talk about what happens, the negative impact if we don't treat depression in our child and adolescent population with serious illness. We'll talk about screening tools and as well as treatment modalities, both non-pharmacological and pharmacological management for treating depression in the pediatric patient. So when we think about just normal childhood development, there's so much physical, cognitive, behavioral, and social development that's happening. They're learning to develop autonomy and independence and separation from their parents and becoming more of themselves and finding who they are as individuals beyond the normal just physical growth and development that's happening to their physical bodies. So then when we think about a child in a serious illness and all of the therapies and treatments and tests that are being done and the uncertainties of that diagnosis as they're waiting for a diagnosis and the uncertainties of the prognosis or how their disease will progress. Or you think about those children who slowly lose motor function, like our patients with muscular dystrophy. And all the therapies that come into play that change their body image and their body habitus, and then just that disruption of the daily lives of going to doctor's office visits or staying in the hospital, that has a major impact on their mental health because it's impacting again their ability to develop. Children that are again trying to gain their independence from their parents often have to rely more upon their parents to be able to function or to do their therapies. And so major mental health and vulnerability in this childhood population of those with serious illness. And when we think about cancer treatments even, some of the therapies alone can impact their cognition and their impact their coping skills, and they often have disordered behavior as well. And really, any diagnosis of a life-threatening illness or a serious illness really impacts the entire family. How does it impact the siblings, and what's their mental health, and how does the mental health of the sibling impact the mental health of the patient, and likewise for the parents? So any diagnosis really does impact the entire family. So again, when we think about depression, what's the scope of the problem? So it's really been difficult to measure the prevalence of depression in children. It's been reported in children with cancer, anywhere from 3 to 38% of children with cancer have depression. The problem is depression in general is often undiagnosed. It's often evaluated as just, well, this is normal. Of course they would be sad. Of course they would be depressed. And so therefore they don't actually treat the child as having major depression. They just say, well, this is normal or expected of the diagnosis. And of course it's not uncommon, and we wouldn't be surprised if a child would have depression with any type of serious illness, but we can't just chalk it up as normal sadness or this is normal and not treat it as its own disorder. The other problem with depression, and we'll talk about the different symptoms of depression and how we diagnose depression, but it's difficult to sometimes identify because the symptoms of depression actually mirror symptoms of other diagnoses. And we'll take a cancer diagnosis, for instance, and we'll talk about how it might be difficult to know if the patient's depressed or simply side effects of the cancer therapy. And then in the literature, to be able to know how often is depression prevalent, it's in the literature, the language is inconsistent. And so it's hard to extrapolate when we look at studies to know what's the overall prevalence rate, because some researchers will use the word distressing symptoms. Some will combine both depression and anxiety when they're discussing mental health symptoms. And so it's hard to tease out how much of it that is depression, how much of that is anxiety. So it really is difficult to measure the overall prevalence and therefore scope of the problem. We do know that if depression is undertreated, then it can actually extend beyond the therapy. Just like cancer diagnoses, for instance, many people will think the common theory is that once the patient's done with their cancer therapy, then the depression will go away because life goes back to normal. Well, what we know is those patients' life isn't completely back to normal. They still have sequelae, they still have long-term effects. They're still going in for, follow-up scans, and scan anxiety is very, very much of a real thing. And so that depression can even extend beyond treatment, even especially if it's undertreated during treatment. What we do know, though, is that the majority of the patients are truly resilient, and they don't demonstrate psychiatric difficulties. Sadness is a normal thing. Oftentimes, I know patients with sadness are assumed that they have depression, right? But sadness is real. Sadness is okay. And so the majority of these children, the good news is, are resilient and overcome their difficulties. So what's the impact of depression, especially if it's undertreated? For example, symptoms of depression can affect quality of life. They don't have the energy level to go be with their friends and to go do the normal things in life that they do. They have a distorted body image, and that impacts their quality of life. We also know that depression can interfere with treatment adherence. Think about children who need to do a lot of pulmonary toileting, right, to get their lungs cleared out. If they lack motivation, they lack desire, they have greater fatigue to be able to get up and do those treatments, that can interfere with their treatment adherence. It's going to have an impact on their overall other symptoms, right, that they're experiencing, and their overall well-being from that diagnosis. Same with cancer treatments. They oftentimes, if untreated depression is, it's not treated, then it can interfere with them taking their medications or doing their follow-up plan as expected. And then, of course, the psychosocial development, again, learning that separation and autonomy and independence from their loved ones. So the DSM-5 criteria for depression, to diagnose major depressive disorder, you want to have at least 5 or more of the following symptoms. They should be present nearly every day for at least a 2-week period, and they also should represent a change from a previous functioning. Okay, so it's not like a buildup. We want to have a change of previous functioning nearly every day. One of the 5 symptoms must be one of the first 2 that you see highlighted. So it must either have depressed or irritable mood most of the day, or the patient must have a loss of interest or pleasure to be able to at least start this diagnosis of major depressive disorder. So again, of the list, they have to have at least 5 or more of the following. One of the 5 must be one of the top 2. So either feeling sad or irritable, or loss of interest or pleasure. The reason why irritability is highlighted here is really because in children, irritable mood is seen more commonly than feelings of sadness or depressed mood that we often see in the adult population. The other symptoms you see here: change of appetite or weight, trouble sleeping or sleeping too much, increase in purposeless physical activity such as hand wringing or pacing, or perhaps slowed movements and speech. You may also see fatigue or loss of energy, feelings of worthlessness or guilt, feeling difficulty thinking, concentrating, or making decisions, and then thoughts of death or suicide. So I want to take this because we talked about how often these symptoms overlay with other diagnoses. So let's take example, a cancer diagnosis. And let's think about a new patient, because right, this is a change in the previous functioning. So let's think about, we have this cancer patient who's starting to undergo cancer therapy, and let's think about the side effects that they may experience from their cancer therapy and how this may also correlate to the symptoms of depression. So feeling sad or irritable, especially we talked about in children, especially noted with irritability. So many of our cancer patients are on steroids. Steroids, as we know, make patients more irritable. So is it the side effects of the steroids, or is it depression? The loss of interest or pleasure in activities once enjoyed, sometimes that's fatigue, right? The sheer fatigue that our patients experience from undergoing cancer therapy sometimes makes it so difficult that they can't, it's not necessarily that they don't have the interest, but they certainly don't have, it doesn't motivate them. The profound fatigue has an impact on their motivation to want to do some of the activities that they used to do, right? Or if they have a change in their body image, that could also impact their loss of interest or pleasure in activities, right? If they feel in any way different from their peers, in any way ashamed of how they look, or not wish to participate in activities with their peers based on their own physical changes, that also may manifest and wonder, is this depression, or is this really just a change in body image? Changes in appetite or weight. Again, nausea, vomiting leads to, lack of interest in eating. Steroids make them want to eat more. So that's going to have, you're going to see changes in eating and weight. Trouble sleeping or sleeping too much. Some of the medications they're on for chemotherapy, or perhaps if they're on opioids, could make them sleep more. Steroids certainly impact the ability to sleep. So again, side effects or depression. You shouldn't see the hand wringing or pacing so much, but they could have slowed speech or movements, again, based on the therapies that they're receiving or radiation treatments. We've already talked about fatigue. Again, we shouldn't see the feelings of worthlessness or guilt as far as side effects of chemotherapy, but certainly the difficulty thinking, concentrating, making decisions, we certainly could see as a result of their chemotherapy treatments that they're receiving. And then, of course, thoughts of death or suicide would not be something we would expect as a side effect of chemotherapy treatments. But you can go through there and think about a cancer patient. And again, when you're trying to count these up, it makes it very difficult to be able to tease out, are these side effects of therapies, or is this depression that we're working with? And then you can see why it may go underdiagnosed and certainly untreated. So some screening assessment tools. Well, I wish I had a great answer for you, but there's actually limited data to support screening for depression in children. Many tools have not been validated for children. And then there's also concern, are the tools validated for those children with serious illness? Because again, we know so many of the sequelae of their therapies for any diagnosis mirror those symptoms of depression. They could either go overdiagnosed or underdiagnosed. So they could be overtreated or undertreated. And so it makes it very challenging to be able to screen these children and young adults with any type of serious illness for depression. There is one recommended tool called a PHQ-9, modified for adolescents. Can be used for those greater than 12 years of age, and I'll show you what that looks like here in a bit. There's a shorter 2-question survey, the PHQ-2, that you can use to also screen for depression, and again, I'll show you that here in a bit. And as I mentioned, none are currently validated for the oncology population. So here's the PHQ-2, and what you see really, the 2 questions are, they're one of those 2 criteria that you must have with the DSM-5 criteria to be able to identify the patient as a major depressive symptom. So that little interest or pleasure, and then the feeling down, depressed, or hopeless. And again, ask how many days in the past 2 weeks have they experienced. The PHQ-9 is really asking about the symptoms of all the DSM-5 criteria, asking about the sleep, asking about appetite, loss of energy, suicidality, things like that. And now the nice thing with the PHQ-9, you can see over here to the right, it does, after you score them, it kind of gives you an idea of what type of therapy to then propose based on that. And so we have anywhere from no recommended treatment actions to simply watching and repeating, potentially do counseling, or maybe consider pharmacotherapy, to all the way to doing both pharmacotherapy and psychotherapy. And then the other is an expedited referral to a psychiatrist or mental health specialist. So let's talk a little bit about some of the treatment modalities. They've looked at literature to look at just using psychotherapy alone compared to pharmacotherapy alone to using a combination therapy. And combination therapy of psychotherapy and pharmacotherapy does have slightly more efficacy than using either of these treatments alone. Now, sometimes pharmacotherapy alone is sometimes needed, because sometimes it's difficult to get patients psychotherapy. And so, or there could be a period of time where getting psychotherapy is challenging. And so you may need to rely on pharmacotherapy initially to treat the patient. Some of the reasons why doing psychotherapy is challenging. One is location. Where does the child live, and are they near a larger center? And are there therapists that are well trained in this? So you first need to think about, you want a pediatric psychotherapist, right? You want someone who understands children. Now we're adding another layer of complexity, children with serious illness. And many of our therapists, who are quite lovely, lack the experience of working with children with serious illness. They're very comfortable treating children who have that are kind of going through a normal process of life, if you will, or normal stressors in life that you might experience in children. But to add that complex layer of serious illness, and again, and really the piece of it is really the side effects that they're also going through and how to tease that out. And also really thinking about, because children with serious illness are really facing issues with and thoughts of their prognosis of will they die based on this therapy. And so it may just be that they don't have a psychotherapist that's really trained in that area. The other component is, if we think about children in active therapy who are like a cancer diagnosis, who are at a cancer facility quite often. And while we like to think that it's very regimented, right, there are some times where there are delays in treatment, or they need to come to the hospital because of fever and they need to be hospitalized for that. And so, if they don't live near the cancer center, and we would prefer them to see a local therapist so that when the cancer therapy is done, they can continue that relationship with their therapist even after the cancer therapy is done. But the problem is they schedule the appointment with their local therapist, and then they need to be admitted to the hospital unexpectedly. And then it's hard to keep the appointments scheduled. Now, I do think COVID has helped a little bit, because I think it's encouraged, at least I can speak for our institution in our state, that I think it's encouraged many psychotherapists to think about virtual visits. So I think that we've been able to have more children continue their therapies because they are offering more virtual visits than what they did in the past. So that's one positive outcome that we've seen in our coronavirus pandemic time. And sometimes centers don't have psychotherapists. For many years, Riley did not have a psychologist that could help our children, but we have a much more robust psychology program now, so that when they are hospitalized, we now have at least inpatient coverage and outpatient coverage for those patients in our center. Again, the problem is when they're done with therapy and they go back to their homes, now they have to develop a new relationship with a new therapist. So in those cases, pharmacotherapy alone might be beneficial for those patients when it's just too complicated to try to coordinate psychotherapy during active treatment time. But combination therapy, again, is absolutely the most effective treatments for moderate to severe major depression. So that's using an SSRI, which we'll talk about in a moment, along with cognitive behavioral therapy. And again, we'll talk about that. So again, psychotherapy. The reason why psychotherapy is so important in depression is because a lot of the pieces of depression are related to the social aspects of their lives. So you have to kind of relearn how to think about or to process your social environment. And that's not done with a medicine, right? That's done with rethinking, reframing, refocusing your relationships and your actions or your behaviors with your environment. And so that's why psychotherapy is so critical for managing depression. We teach them ways to better understand themselves and what is really the crux. What's the trigger of causing my depression, and how do I fix that? It helps them to manage relationships, and again, those life stressors, helps them with coping, improving their social and self-management skills, and then also increasing their self-confidence. So we've talked about most of these in terms of considerations for psychotherapy. One is the relationship. Not every therapist and patient are going to connect. And so you really need to, find one that's good, a good team, right, to work together. We talked about the availability of qualified health professionals, what's their approach to treatment and experience, again, in treating patients with depression with serious illness, and is the family supportive of the process? Because if families and parents aren't supportive and they don't believe in the components of psychotherapy, they may have issues with bringing the child to follow-up appointments, but also motivating the patient to keep doing the work that they need to do, unfortunately. And then we talked about proximity of the therapist. So there are different types of psychotherapy. We're going to talk about just the cognitive behavioral therapy. The first two are the only ones that have really had randomized studies to show, controlled research to show that they are effective. But we're going to talk about CBT. So CBT, or cognitive behavior therapy, is really thinking about, we have our thoughts, beliefs, and our attitudes, right? The cognitive part of us. So how are we thinking, and what do we believe, and what's our approach or attitude to a particular trigger or person or situation? And then we have our behaviors, right? So our thoughts impact our behaviors, and that's how we outwardly emote. So what we actually bring to the table, right, in our social world. And so the thought behind cognitive behavior therapy is that it's the assumption that we can alter our thoughts and our behaviors, that thereby kind of change our emotions and how we interact with the world, in other words. And so the treatment components of CBT is really helping the individual find those pleasurable mood enhancing activities. What makes you happy? What brings joy to you? What gives you those kind of endorphins that kind of enhance your mood in a positive way? And let's increase those experiences, right? Let's increase those social interactions, the people that really bring you joy, the people that really make you in a good mood and put you in a good state. Let's increase the quantity of those interactions. Or if we can't still increase the quantity of we still have those negative experiences we have to encounter, but how do we improve the quality of those interactions? How can we take that negative interaction and kind of change it a little bit, maybe give you conflict resolution or problem solving skills in ways to approach that, so that it's a little more of a positive outcome, or at least your expression is more positive. It also, cognitive behavior therapy also helps to reduce physiological tension. So oftentimes in negative situations, we become very tight. Our heart rates may increase, our breathing may increase. And how can we think about how our body's reacting to a situation, and how can we bring that down? How can we lower our breathing, lower our heart rates to be in a more open state for those situations? And then also finally modifying or restructuring, again, our depressive thoughts that we have. So a typical course of therapy usually it's outpatient. You don't certainly have to be inpatient for cognitive behavior therapy training. Usually they recommend weekly or biweekly sessions, about 12 to 15 sessions over an 8 to 18 week cycle. There is some literature supporting some booster sessions once you've completed kind of your initial upfront therapy for CBT, usually done about every month to every 3 months, just to kind of retouch and kind of kind of remind the individual on how to do the CBT work. Oftentimes therapists will give them homework assignments so that they can self-monitor. Notice those situations in which you find yourself getting more irritable or more sad, right? And even activity scheduling for those activities that they find more mood enhancing. Usually discontinue CBT when the resolutions of symptoms exist, and which means they're doing the CBT with great success, right? They've got that down pat. And then they have a sense of efficacy to maintain the gains. Again, they kind of know how do you put this into practice. Now switching gears a little bit to pharmacotherapy, why would we use pharmacotherapy? So if we've identified moderate to severe depression, if you remember that PHQ-9, it didn't call for use of pharmacotherapy when the score was relatively low. So only when they get to moderate to severe major depression, we think about adding pharmacotherapy. Or if the depressive disorder is persistent or severely impacting their function and ability to kind of function with life. Or if they've done the psychotherapy and they're not responsive to it, then we may need to add pharmacotherapy. Really important to do a lot of education with our families before starting pharmacotherapy. We need to talk about the risks and the benefits, right, of pharmacotherapy. There is a black box warning for suicidal ideation. So we need to talk about that, but we also need to talk about the risks if they don't do pharmacotherapy, right? That too can increase morbidity and mortality in our patients if they go untreated, as we talked about earlier. We need to talk about the side effects. And one of the key things too, I think we need to talk about how long does it take before we see improvement once we start pharmacotherapy. I've had many patients who said, yeah, I tried medications and it didn't help. Well, how long were you on the medication? 2 to 3 weeks, and it didn't work. Well, that's because we don't expect it to work in 2 to 3 weeks, right? We need a good, 6 to 8, maybe even 12 weeks before pharmacotherapy is really effective. Certainly may need to titrate medications as well for it to be effective. We also want to talk about, when would we stop this? Why would we stop pharmacotherapy? What are we hoping to achieve? And we'll start to wean that pharmacotherapy. And then also, I think it's important to tell families not to abruptly stop any medications without weaning as well. Other things we need to think about when we start pharmacotherapy is we need to assess for the presence of suicidality, psychoses, anxiety disorder, a bipolar disorder, or a substance abuse disorder. We also want to ask the patient and the parents, have they been on any SSRIs or SNRIs, and what medications have worked and not worked? And again, why do they not work? Because oftentimes if a parent has trialed a medication and it didn't work for them for a legitimate reason, not just because we didn't give it a fair trial, then oftentimes it won't work for the child, or at least I won't start with that medication for the child. And so that's why it's important to kind of hear the history of the parents and what medications they've used as well and what's their experience. That will sometimes also dictate the motivation, right? If they feel like a medication is not going to work that they've tried, and then you're going to try putting their child on that medication, it often doesn't go well. So I just try to set it up for a success as much as I possibly can. And then they do recommend urine pregnancy testing for all post-pubertal females before starting them on psychotherapy agents. So the first line for pharmacotherapy is Prozac or fluoxetine. It's an SSRI, or escitalopram or Lexapro. Now, if the patient has concurrent anxiety, they do recommend doing Lexapro versus Prozac. The interesting thing is when you listen to the anxiety lecture, one of the first line agents for anxiety is Prozac. However, what I've been instructed by our psychiatrist, and I will encourage any of you going into palliative care to have a psychiatrist number in your phone contacts that will not be hesitant to allow you to do sidebar consults or curbside consults with them. I often will refer to our psychiatrist. I'll manage simple depression or anxiety without referring to a psychiatrist, and we'll talk about when to refer to a psychiatrist in a moment. But it's never a bad idea to have them on your contact list to be able to reach out to easily. But what they tell me is that if the patient has both depression and anxiety, actually they would not recommend using Prozac, because if you're treating the depression, it actually heightens the anxiety. No one can really explain to me why it will work with just anxiety alone and not heighten the anxiety, but it's the combination depression, anxiety. If you use Prozac, it will intensify the anxiety for the patient. So if they have concurrent anxiety, they recommend using Lexapro, or the second line therapy, Zoloft. I will tell you, my own preference is I actually treat with Zoloft. I actually don't use a first line agent listed here for depression. And the reason I do that is because when we talk about treating anxiety, Lexapro is not on the list, but Zoloft is a first-line agent for managing anxiety. And that way, if we misdiagnose the patient for having both depression and anxiety, then right, that I know I'm covering both. I'm just treating depression, I'm covering the patient if I'm just treating anxiety, and I'm also covering if they have both. It's also much like, I feel like psychotherapy or pharmacotherapy is much like opioids, right? Most providers are comfortable with like kind of one opioid. Most general practitioners are comfortable with morphine, right? They're comfortable with the dosing of morphine and they know that very well, and that's what they'll prescribe, or it's oxycodone or hydrocodone. And they kind of use that as their first line. I also find that it's the same for this, right? You kind of find an agent that you're comfortable with, that you know how to dose, and that's kind of your go-to. So, and what you'll find, much like opioids, is that what works for one patient won't necessarily work for the next patient. So my first line for both is Zoloft, actually, versus the second line, which is what the literature says for depression. Another option is venlafaxine as an SNRI. And then if you're moving to a third line agent, then you should refer to the psychiatrist. So I'm not going to spend time reading you the doses and reading the slides to you, but I just kind of want to show these are doses to you. I do want to kind of give you a general, kind of some of the general key concepts that are across the board. First of all, Prozac has been FDA approved for children 8 to 17 years of age. Again, not recommended if there's a concurrent anxiety, depression disorder. But as when you look at most of the dosing, you want to start at a low dose, do that for a week, and then escalate after 2 weeks, and then kind of watch after 3 weeks, and then potentially escalate if you don't see improvement. But of course, full response may not be seen for 8 to 12 weeks in any of these agents. The other thing I want to point out is oftentimes we'll tell them to use it at bedtime because it can cause drowsiness. However, in some patients, it causes insomnia. For those patients, you want to have them dose that dose in the morning versus nighttime. And that, again, that's true for all of the agents. So here you see for Lexapro, it's FDA approved for those 12 to 17 years of age. Zoloft, you see the dosing and information there. Again, very, very similar. And then venlafaxine. I think the downside to venlafaxine is it's a BID to TID dosing. And so it's more difficult to dose, right? It's obviously more complicated to remember to take a medicine twice a day, but especially 3 times a day is really challenging for those kids that are over 40 kilos. So I think that's, to me, one of the downsides to using venlafaxine. And then, of course, when we're prescribing medications for depression, and we want to think about the SSRIs and SNRIs, we want to think about serotonin syndrome. And the overstimulation, this can actually be lethal, right? So it's an overstimulation of central and peripheral serotonin receptors. And how I kind of think of it is kind of like that autonomic instability patient, right? Instability patient that, where their heart rates go up, their breathing may go up, they're super agitated, they have increased bowel sounds, their bowels are and they may have diarrhea because they have over stimulation of the bowels, they have hyperreflexia, clonus, kind of this hypersensitivity is kind of how I like to think about it. And so management is to stop the medication. Of course, you might want to wean, and we'll talk about when we wean the medications in a bit, and then do supportive care aimed at normalizing the vital signs, of course. And then, of course, be cautious for patients that are on multiple medications that might stimulate the serotonin syndrome, such as trazodone, Tegretol, tramadol, Zofran, and many over-the-counter cold medications. And then, with our oncology population, they may be on methadone as well. That can also sometimes cause that. So in terms of discontinuing pharmacotherapy, usually you'll continue therapy for a good 6 to 12 months, even after the remission. The depression is kind of managed, as you will. And we do that mostly to avoid relapse. We don't want to stop things too quickly because we want to make sure everything's kind of in place and they've, again, got that psychotherapy kind of training in the background that they can rely on if they notice symptoms returning. If they've been on the medication for at least 6 to 8 weeks, then or more, then we generally recommend tapering versus stopping suddenly. Obviously, we want to taper by about 25 to 50% dosing a week to avoid the withdrawal symptoms as you see listed. You want to refer to a psychologist or psychiatrist if there's any uncertainty of the diagnosis or major depression, or you're just simply uncomfortable managing pediatric depression, of course. If there's any noted agitation, suicidality, homicidal behavior, or any history of suicidal attempt in the recent state, then you would likely want to refer to a psychiatrist. If there's any presence of psychotic features, delusions, or hallucinations, bipolar disorder, if the depression is recurrent or chronic lasting more than 2 years, or if there's severe functional impairment, you want to refer to a psychiatrist. And then, of course, if you've tried 2 lines of therapy that have the patient's not responded to, then you want to refer to a psychiatrist as well. And then I just want to talk briefly here about the emergency management at end of life. So obviously in palliative care, we are dealing oftentimes at really more critical end of life time where we may not have the 4 to or 3 to 4 months to wait until patients have responded to those pharmacotherapy agents. So we might need something a little more critical in time. So of course we want to think about the trajectory. Do we think the patient has days to weeks, or is it hours to days? So if it's days to weeks, first-line agent, you could use methylphenidate or Ritalin for management of depression, or you could use something like mirtazapine or Remeron for depression. If you're thinking hours to days, then you really want to be very aggressive with symptom management, because most likely it's the symptoms of depression of dyspnea or pain or insomnia, nausea, vomiting, itching, things like that might be causing the depression because maybe they're not able to sleep or get good rest. Or they're even just recognizing it might be closer to the end, right? So you want to be super aggressive at managing symptoms and adding that emotional support at end of life. And then certainly you could also add ketamine. It's getting more widely known for managing depression at end of life as well. And I just want to thank Catherine So and Jessica Meyer, who were both third-year psychiatry residents at the time of them helping me with this presentation, and offering their expertise and guidance along the way and filling in the gaps, because I am clearly not a psychotherapist. I am a palliative care advanced practice nurse, and so they were very gracious in helping me with this. So thank you very much for joining me today.